So let's shift gears a little bit. Talk about education of the patient and family. We've all talked about that. You spend time doing that. You spend time doing that. Can we talk about what are the essential components? What do families need to know before they leave the office that first time?
One of the most important things I do at every visit for every family, although these days most families already know about the Tourette Syndrome Association, is make sure they're aware of
Thank you very much.
TSA, the resources, the literature, the chapters, the membership. Most families know about it when they come in, at least people we see, but occasionally some don't. Or you've just made the diagnosis or you've confirmed it, and it's good to tell them about the organization.
A big pitch that I give is the notion of range of severity, that just because the person is now into the diagnostic classification of Tourette doesn't mean that it'll be severe. It doesn't mean that they've tipped into some new zone, that they can have Tourette where the tics are mild or Tourette where the tics are severe. And then that goes easily into the issues of looking at the whole kid and where are the other strengths and where are the other weaknesses, and to kind of get their mind off a little bit of the tics, because that's usually a little bit of the horror story, is that they're saying, oh, Tourette syndrome, as if that's a progressive thing where today it's this, but tomorrow it's going to be worse and worse and worse. So, and it goes to the whole story of ADHD, learning disability, OCD, anger management, all those kind of things.
I think I try not to, and I do this a lot anyway, but I try not to presume that I understand what these labels and diagnoses and whatnot have meant to the family. I may very well be that this is not something that this label comes as a relief to them, or it might be come down like a sword, and so I need to understand that as well. I also want to give them, my time is very limited with families too, so I do want to give them a sense of continuity. It's not something that I especially have. So what it is that I tell them and what I put in my reports as well is that I'm not their doctor, I'm the doctor's doctor, and what I'm doing is I'm helping their doctor understand this so that they can be more available too. And I insist that an appointment be made once my report is available to meet with their primary care provider so that they can discuss this report and then contact me if there are any further questions. The Tourette Syndrome Association is one of the resources I always mention. We now have this terrific video too. I have Tourette's, but Tourette's doesn't have me. I was in Australia a couple of weeks ago, and I gave a talk to the Tourette Syndrome Association of Australia. The organization there opted to show this, and it was amazing how well that was received. There was a standing ovation at the end, and it just it really provided, I think, a lot of inspiration and hope to a lot of the families there.
So it's what to expect in terms of Tourette syndrome symptom severity over time, what to expect about the evolution of comorbid conditions over time, with some idea as to kind of how many people are going to have severe problems, that sort of business. Also really spend a fair amount of time about using this evaluation as an opportunity for the family to take stock of how it works together, how mom and dad are doing, how mom and dad relationship is doing, asking them to think about kind of overall parenting skills and to do a self-assessment and maybe use this evaluation as an opportunity to take on some of those things that they wanted to do as a family for a long time but they haven't. Are there some issues, are there some things you definitely don't say to families, or have you heard other people say to families that you wouldn't recommend they say to families? Any don'ts?
But let me, before we get to the don'ts, if I could interject, beyond the objective information that you're providing, which I think is sort of the basics, I think that for the adults and the children that I see, they come in already wounded from some of the misinformation and the accusations and the assumptions that we're about to talk about. So it's very important beyond the first level of communication, which is the accurate, sound information that you're going to give, that you can convey in ways that are sometimes subtle, that you like this person, that you really are their advocate, that you're on their side, and that in spite of what he may or may not be doing in the room, including, ticking and raising their voice and so forth, that you actually do accept them for what they are and begin to use that as what the psychiatrists used to use the term transference. And before and unless you're able to establish that rapport with the individual, it's very difficult to exercise the leverage that you need with the information that you've given them.
Boy, that's such an important point. I tell our trainees that there's two things happening in the evaluation. You're evaluating the patient, and the patient's evaluating you. And more often than not, we fail the evaluation before they do. And so I point well taken. We've got to do some things during that interview process that seal the deal in terms of having credibility as a good evaluator and as a person who can offer treatment in a reasonable and responsible way.
I found over the years of doing this that one thing that's so important both to feedback to the kid and the family when you're pulling things together, and I put it in the written report, is to look at what the child's strengths are. Because I've been so impressed with these kids with how much strength they have as individuals in very special areas and how many of them cope so well. And I will always say that before I start to talk about here's the list of diagnoses and here's what we need to think about for intervention, is here's what your child's strengths are, and this is what's going to allow you to work with these diagnoses and problems, because he copes well, he's got friends, he plays baseball, to kind of remember that that's part of our formulation. And I think that probably goes a long way to the patient's evaluation of you, because they realize that, you know, you're looking at more than just these symptoms, you're looking at the whole person there, and I think that's so important.
I was going to say that's one of the don'ts, is don't forget the strengths. And the other don't for me is the to remind parents to avoid the deception that treating the tics will treat the whole picture. Another don't.
Yeah, I would agree with Barbara. I mean, I spend most of the time really trying to get what's the terrain, and so are they how are they functioning in all their spheres and things like that. And again, my population, so often, again, these kids are diagnosable as Tourette syndrome, but they function very well. And there's something about small towns, too. I mean, people are very forgiving. And so what becomes apparent to the families, I guess, because of my focus, is that, well, you know, this really isn't so bad. And I think they leave with a better sense of, you know, that there's some hope, even though you've really just educated folks. Yeah. And I'd put a plug in for the TSA website as well. More often than not, I think they've Googled Tourette syndrome, and they must get something else before that, because most of the time people are coming in hoping to God, I'm going to say, not that I'm going to say they have Tourette syndrome, because they've read somewhere else. So I tell them there's only one website they can look at.
Sam, do you have any don'ts?
Thanks. And actually, everybody has addressed this, and I'll address the same thing, but maybe in a different way. It's important to understand the strengths, but I think it's also important to understand that other people don't see the strengths or the palette. They often see the disorder, and it's important, and the child and the family end up often perceiving the child this way as well. It's an incident. They want to work toward, I think, a place where it's an incidental, interesting, quirky, somewhat challenging thing that is not in any way consuming of the identity, and that's important to do.
Yeah, no, that's a big one for me. I guess the other piece is that there's some wish or dream for the patients that I see that the world would love their kid like they do, accept their kid like they do, be kind to their kid like they want them to be, that somehow this youngster's life would be made easy tomorrow. And I try really hard not to buy into that idea. Because what it does is it sets me and the family against the world. And over the long haul, it's going to be better for me if the family and I side in a way to kind of win the world over, if you will, as opposed to try and get the world to change. And it's a subtle difference in approach, but I think it makes a big difference when families realize that they have an ally to take on some of the challenges as opposed to an advocate who's going to fight their battles for them. I do fight battles for these kids, but for me, it's more about winning the world over than it is than trying to get the world to change its ways.
That's how I sort of address the treatment issues sometimes. Is we ascertain that the tics aren't really bothering the child, the parents can live with them, but they're worried about what they'll say at school, et cetera. And I said, so I understand all that. you want me to put them on a medication that may change their behavior, change their body habits to make other people happy? And almost everybody says, no, we don't want to do that.
Yeah.
So you do become their advocate, and that you're going to work with, to win over the world. I like that.
The whole concept of not to worry, it's not a don't, but I often tell parents not to worry about their kid because the kid is coping pretty well. There's now some converging evidence that tics get better after, before adolescence, before puberty. And so just reassuring them that your kid has a lot of strengths, your kid is coping well. Yes, the tics are problematic now at age 9 or 10, but chances are they're going to improve as he gets older. Goes a long way to helping parents relax about it. Because many times, the parent is more concerned about the kid's tics than the kid is himself or herself.
Do you tell people that they're going to outgrow it? That's what other doctors tell, that they're going to outgrow their tics? Or the parents ask you, are they going to outgrow this?
We say that the tics will likely get better.
Yeah, I don't do the outgrow thing.
Yeah, I don't either.
And I don't. I reassure, but I don't reassure too quick because sometimes if I do a premature reassurance, I lose credibility. So it's a tricky thing about how to do that reassurance because he told me it was tic disorder, could be Tourette's, and told me not to worry about it. It'll probably go away, and that was enough to get them on guard for seeking a consultation. So.
We never say go away. We never say outgrow. We say there's scientific evidence, some preliminary scientific evidence, including some I've published myself, to show that tics do tend to generally get better in many children, but you can leave it at that. Yeah. There's epidemiologic evidence. There's the Yale Child Study Center's pediatrics publication in 1998. There is some evidence there, and you set the stage for what it is, but you can't say they're going to outgrow it.